Thank you for introducing me, and everybody, thanks for tuning in. I'm not sure who is in the audience, so I'll just spend a quick few minutes identifying exactly what a doula is, and then I'll move on to describing how doulas are utilized through our volunteer program at UC San Diego Medical Center. So that's my goal, is to identify the role. And I'm sorry if this is overview or too much for some of you, but I have found that really it's still a field that is a little bit confusing to people. So, but in a nutshell, why we are here is because doula care and labor support are of interest regarding lowering cesarean rates and increasing patient satisfaction. We do know that women's utilization of doula care varies widely. Our program is just one model. There are many more, but we are proud of our statistics, and we provide awareness and access for people in our community and beyond, and we do emphasize collaboration with a women's healthcare team. So again, just real quick, what is a doula? Not the same thing as a midwife. I get that one all the time, and I do think it's because there is still some confusion about what midwives do. Doula has been described as a supportive companion other than a professional, other than a loved one, and professionally trained to provide non-clinical care. That continuous one-on-one support is really what has been shown to reduce fear and anxiety that can slow labor. Another of the doula's tricks of the trade, so to speak, is just to really provide a lot of comfort and pain relief for the mother, but also to help with maternal positioning. And that has been shown to not only ease pain, but to help descent and rotation of the baby. Another key point is that ability to be an ally in all directions. That's what I strongly believe a doula is aware of and available to do, non-stop, non-replacing the family, and for any kind of labor and delivery. And in our hospital, by the way, our doulas are welcome at any kind of birth. I know that's not the case everywhere, but we've been within our organization for 17 years now, so we're pretty well known and trusted in just about any kind of situation. Our support does continue early postpartum as well, where we can help clean up, take photos, help with breastfeeding, and that's not in response to the mother's situation only, but our staff is looking for our help that way as well. So many of the studies have shown all of this information, which I believe if you're watching this webinar, you already know. A useful decrease of the length of labor, which also in turn influences the need for interventions, the need for pharmacological pain relief, and a pretty significant decrease in the cesarean section rate. NICU admissions decreased as well, and also an increase in maternal and paternal satisfaction and confidence. But did you know that most of our healthcare associations now, including obstetrics, maternal fetal medicine, pediatrics, anesthesiology, midwives, and nursing, are all recognizing the benefits of labor support? We're seeing language about it in many articles and policy updates about reducing the primary section rate, including these. Again, I think you're probably familiar with this. So the obstetric care consensus that came out in 2014, published jointly by ACOG and the Society for Maternal Fetal Medicine, speaks about incorporating labor support and mentions the word continuous. That's my underline. And the CMQCC, the reason we're all here today, also recommends incorporating labor support and mentions working collaboratively. And again, I'm so sorry for this presentation. It's really thrown me off too, but bear with me. I do think that the continuous emotional support is the most important essence. It's valued muchly by families and maybe least by healthcare staff who don't really notice it when a doula is sitting quietly in the room, not appearing to do much. But a woman could be not yet in pain or comfortable with an epidural or even at a cesarean birth and still struggling quite a bit emotionally. We hear a lot about all the things that women fear during labor, and we also fear being alone, even though there's a lot of people nearby. I can't say enough about this, really. Nurses often say they would like to be in the patient's room bedside more often, but they're busy with equipment, charting, sometimes other patients. And mothers report that they feel alone, even with great family support and good medical staff. So doula's number one goal is to help a woman feel safe and confident. It's pretty well known that women can have a longer labor when they fear and stress the labor itself. So when I talk to a lay audience, I simply say adrenaline suppresses oxytocin. And even after the pain is relieved, she has a lot of anxiety and other discomforts that a doula can attend to. So she does greatly continue to appreciate a doula's physical care and comfort, but also just the continuing reassurance from somebody sometimes just calmly sitting with her through the hours. Physical support, obviously, pretty important too. So who else has the time and the know-how to offer comfort measures to both the mother and her partner like this? Because she can do it nonstop. Over the course of time, she notices the change in the labor pattern, perhaps, and she can change her support accordingly. Sometimes the doula is the one who's noticing things like perhaps signs of an OP presentation, and then can really work proactively with the mother regarding movement and things to try to help turn that baby. I love this photo. In this one, you can't see the doula at all, but she set up this scene. She went and got the sheet and the squat bar. She encouraged the dad, showed him how to help, and she's guiding the mother to listen to the provider's instructions to pull, and then whispers in her ear to listen and perhaps pant and not push. And mothers really like to have at least one person up by their head instead of everybody down at their perineum. And our nurses and anesthesiologists, by the way, recommend and recognize the ability of a doula to just hold and support a woman through an epidural placement. I know that's not allowed in all hospitals, but our staff really feel like it's a busy clinical time, and they appreciate that kind of teamwork and collaboration.
And this is Valerie. I'm just going to interrupt for just a second. People on the line are saying they're having a little bit trouble hearing you. Can you talk just a little bit louder or more directly into your phone?
Okay. Sorry.
Thank you so much.
Okay.
We'll have to see if that works better for people.
Okay.
Thanks.
Let me try this again. I'm so sorry for the technical difficulties here, but please continue to bear with us. So, okay. Our interest always, healthy mother, healthy baby. I think that's a common goal, but we all do bring different values and beliefs and certainly different expertise in our efforts to provide care. And I do want to say right up front, I know that there are times when doulas are not seen as part of the team, perceived to be disruptive or difficult to work with. And a lot of that I've heard is actually secondhand. People's stories are passed on, and it's the one bad apple story. But most doulas, I think, do well by established standards of practice and code of ethics that they're following. And when they communicate well with the staff as well as their families, the working together is really enhanced. So I do think for doulas listening and doulas I train, certainly we spend a lot of time discussing how to be part of the whole team. It's also important, I believe, for medical staff to know that they have a route for making formal complaints if they need to. So, and sometimes I'll also, acknowledge that it might appear that it's the doula's agenda when it's actually a difficult mother whose choices and manners are a bit adversarial. And it's great when the doula can be the one to help smooth the waters and bring everybody into a more effective discussion and relationship. So when our doulas good allies, the rest of the time, most of the time, it's a beautiful thing when a doula can support the hospital team, the mother and the family by staying continuously, focusing on just her safety and confidence, looking after the family as well so that they can either be active in the role or get some support when they need it as well. The conversation between healthcare staff and family and patient sometimes is short and difficult for a woman to understand. When she's in labor, we know that she's kind of somewhere else sometimes. So the doula sometimes will just work to translate the words into something she can understand a little bit more, and she'll repeat it when the woman can actually digest it. She also follows up with the woman at home and reiterate some of the information that the discharge summary was given, but not digested. Okay, so doula sounds like a good idea. Where do we get doulas? There are basically two ways, essentially. Doulas working in private, independent practice, and doulas working in a couple of different kinds of programs. So at least in my community, San Diego is a pretty big city. There are many, many private doulas. They're hired mostly at a flat rate. There are several doula associations locally for support and backup and for business practices. And a family, if they know about doulas and they can afford one, then they have a lot of options. But there's still many people who that's not an option for because they can't afford it, frankly. So as well as the very good private doulas in town, our doula program is something that caters to people who cannot afford it or sometimes just didn't know they were going to need a doula or want a doula when they got in the throes of labor. So the other options for doulas or accessing doulas are community-based programs and hospital-based programs. And I've known of at least 60 hospital and community-based programs that have started in the U.S., not all still thriving. But in some communities, there are some wonderful nonprofit organizations that work to attend to women wherever they choose to deliver. And some of those models include peer doulas who are recruited from the same population, which is a great idea. Hospital programs like ours are a bit more varied in structure and in service. For example, where I live, there is one hospital that provides a referral service to paid doulas that the hospital has vetted. There's another hospital working to develop a doula network somewhat similar to ours. In fact, I'm trying to work with them and help them out a little bit. And then there's our program, which I'm going to tell you more about. So here's the UCSD Hearts and Hands Volunteer Doula Program. We are within the University of California's UCSD Medical Center, which is an academic health system, in other words, a teaching hospital. And we have 2 locations now. We just opened a new hospital, the one on the right, in November. So one of our challenges now is to serve 2 different locations. And if you squint really hard, maybe you can see me up there on the 9th floor. My office is right in the middle of our labor and delivery and birth center unit. So we do have all kinds of physicians on our labor and delivery unit, our midwives. We have about 16 midwives. They're practicing in labor and delivery as well. And in our in-hospital birth center where there's only midwifery care. So we're pretty proud of that, as well as our level 3 NICU and our baby-friendly status. And we're seeing about 2,500 deliveries per year. So our program in particular, there was an earlier attempt, it didn't really fly back in the early 90s, but then we tried again when the birth center opened up within the hospital itself, and that was in late 1999. That was a partnership between volunteer services and our women and infant services. And the midwives themselves really were the impetus for starting the doula program. And then it was developed for a couple of years with just some volunteers and 0 funding. We organized and developed the program ourselves, starting with just the midwives, but then eventually we had enough just presence that we could offer doulas to both physician and midwifery patients. We really got on the map a couple of years after that when we received our first grant, and that first one was from the First 5 Commission in California, and then the second, even larger grant through the California Endowment really helped us to set ourselves up. Current funding is through our hospital budget and women and infant services covering our salaries for myself and one other partner. And volunteer services covers all the credentialing that the volunteers are required to go through. So I do get a lot of questions about why a hospital program, why a volunteer program, and sometimes people aren't so sure that that's a great idea, considering the you get what you pay for attitude, that free isn't worth much, perhaps, or that the doula volunteers are not able to truly advocate for the woman because they're part of the organization. Some people wonder if our doulas are all just brand new doulas in training, or they wonder perhaps that they're going to take business away from local private doulas, or even that volunteering in general disrespects the professional business aspect of doulas today. I can tell you that that has not been our experience at all. Our doulas are very well trained, experienced, mentored, supported in their work. And in fact, some of our doulas are also the same doulas that are in private practice and get hired in town. Myself included, in fact, and doulas do get hired based on their experience as a UCSD volunteer. So I think that helps everybody. And really, I don't believe there are downsides. There are other great models as well, but what we value about ours is that our healthcare team truly values our trusted labor support, especially for some of our more vulnerable populations. We do kind of serve all comers here in San Diego. Our patient experience and marketing departments highlight the program as something that no other hospital in Southern California has. And some families even switch care to come to UCSD for the doula program. I've had people say they've even switched insurances to come to us. So that's a plus for the hospital itself. And financially, we've brought in quite a bit of money to sustain ourselves over the years. So when budgets are scrutinized, we still survive and are not affected. Okay, so the powers that be at UCSD have made a huge commitment to supporting our program. So along with the many benefits to a pregnant woman herself, here's how we think that others benefit as well. Sometimes nurses comment that doulas have all the fun of their job regarding labor support and emotional care, and that leaves them to chart. But doulas do change Chuck's pads, clean up messes, go get blankets, peanut balls, ice, and often, staff can be short-staffed, or even dealing with something called compassion fatigue, a term I heard recently. I've seen it for years, but I didn't know there was actually a term for that, but I think you understand what I mean. You get burnt out after a bit. So our staff do appreciate that compassionate, personalized, ongoing care, and they like working with doulas that they get to know very well. Our pediatricians and lactation department really like it when doulas stick around to encourage skin to skin and help a woman get latched with that baby, particularly in recovery if she's had a cesarean birth. But at any point in time, we think that we can really help the staff with that early postpartum time when they're busy with other things as well. Sorry, trying to advance these slides. Okay, what's in it for the doulas themselves? Well, some of them are just plain birth junkies. They love the experience over and over again. Some people did investigate volunteering for other reasons and didn't even know about doulas, but when they found our program, have just stepped into it and stayed with us for years. Others are younger women who are using it as a stepping stone to careers in healthcare. And these days, having a doula experience on a nursing application is going to get you in the door quicker, I've found. Scheduling is obviously much easier. Our doulas, I'm going to talk in a minute about it, but our doulas work mostly on call. They do get a much wider variety of experiences than private doulas can generally have access to. And our doulas really say that what keeps them here is the mentoring, the overarching support 24/7 by our program staff, and the feeling that they're appreciated by the team here as well as the families they work with. So in return, we offer all kinds of wonderful experiences, but we're very picky about who we recruit into our program, and what it takes to volunteer with us looks like this. Potential volunteers are in it for the reputation of our program and the level of support they can get. But in return, they have to start with a rigorous phone call with me and my assistant, Heather. And If they move through that, then volunteer services takes over for a bit. These are the requirements for any kind of volunteering at our hospital. And if you're listening in from a hospital, this all looks familiar. I'm sure it's the same pretty much anywhere. Minimum volunteering commitment of 6 months and 100 hours before anyone would even get a letter of recommendation or confirmation of hours for those job applications and nursing school applications. So they can't dip in and out for just a little while. They have to stick with it for a bit. Volunteer services is going to cover their background check, their immunizations, TB, flu shots, annual safety and HIPAA training, which is done online. And it's up to the volunteers themselves how quickly or slowly they get through all these requirements. But once they have achieved all this, then they get a photo ID badge that says they are part of UCSD. That's done through our security department. And even before that, they are, as I said, screened pretty heavily over the phone. We describe the commitment as being a minimum of being on call for twice a month, 48 hours clear each time that they are on call. So if they can manage that physically and emotionally and with their personal life, then they're invited to a 2-day introductory training. And this is in-house, it's required. We offer it every other month. And regardless of what experience level they bring, they're going to sit the training with us. It's our way of screening them a little further and for them to really get to know us as well and ensure that it's a good fit. After that, 4-hour orientation to the facilities. That includes our policies and procedures and a little bit more hands-on training. And initially, they're going to work with mentor doulas for a few births anyway. And again, that's even if they come to us with a good level of experience. We want to ensure that they feel supported, that they feel confident, and we want to feel that way about them as well. Another way that they receive more training and support is through our monthly in-services at our meetings, and that's another way just for the doulas to really commune with each other and get to know each other. We also have, nothing's mandatory, they're volunteers, but every quarter we offer 4-hour breastfeeding workshops for free. As a baby-friendly hospital, we do feel that that's pretty important as well. So, okay, let's look at some outcomes. This is a slide I'm pretty happy with. This is for the calendar year of 2016. You can see 2/3 midwife patients, about 1/3 low to moderate to high risk physician patients, and significantly more primaps in this population than multips. And non-pharmacological pain methods used, or no pharmacological pain methods used is 41% of that population. So doulas don't push for unmedicated labor, but they have an expertise in supporting women that way and no fear with working with them. So another side effect of working with a woman this way is to simply avoid the downsides of getting a early epidural, perhaps, even if she's wanting one. No one's going to talk her out of it, but we might try to at least get her into active labor if she can. And by the way, none on the bottom of that slide means that a woman chose narcotics or nitrous and then also got an epidural later. And the next slide I also quite like because it shows our cesarean rate. In the same population, 12.3%. That's a pretty good cesarean rate. In a hospital like ours, it's, again, midwifery patients are by definition normal, low risk, but our physician patients do vary all over the place, low risk, high risk, and this number includes some very high risk women and some planned cesareans. So we're pretty happy with that number. By the way, we also have a new policy regarding doulas in the OR. That means our doula plus a family member can both accompany a woman into surgery. Unless there's some emergent medical reason to opt out, it's going to be standard, is already standard for 2 people at the head of the mother working with anesthesiology nearby. And I mention that because we do stand next to the anesthesiologist, so it's kind of up to them to opt out if they need to or want to, but otherwise we're in there supporting both the family member and the woman herself. And you might imagine patient satisfaction has been high thoroughly from the beginning of our 17 years on. Our doulas make a phone call about a week postpartum to remember the birth with the woman and to bring closure to this experience. They get pretty emotionally involved, even though they've generally never met in advance, because they step in when the woman really needs them and wants them. And we've got nothing else to do. We fully focus on them for whatever amount of time it takes. So we get a ton of verbal thanks done. We see it in Press Ganey. We get love letters every week, sometimes a number of them. And literally, I've gotten some years later, which is quite fun. We also receive a fair amount of monetary thank yous too. And those aren't just from the grateful families, but sometimes from our own healthcare staff and even the volunteers themselves, those who are able like to contribute. So, but I love this particular note that says that the staff was very helpful. But she says, however, I was not truly at ease until Candace arrived. I've never met her before, yet she seemed to know exactly what to do so that I was relaxed as possible. And in this birth, Candace was there for 15 and a half hours. Her personal record is 46 hours. And as you might imagine, that was a induction with a primip, and Candace stayed the whole time and came back for more. So how do we use our doulas? This is the way most of the doula work is scheduled. It's on call, free to any family. The doulas are on call for a 12-hour period, either AM or PM, but they're agreeing to come in within an hour of that call whenever it comes during the 12 hours and committing to not leave until the baby is born. And sometimes, as I mentioned, that is quite long. Sometimes it's a oops, missed the birth, and other times they're there over a number of shifts of staff coming and going. We do particularly have an interest in serving our special needs population, but we offer it just first come, first serve to anybody who would like to request a doula with us. And I do know that not all doula programs schedule their doulas this way, but it has been our philosophy of care since the beginning. And we've been very grateful to have volunteers who make this commitment for years at a time. This picture, by the way, is Kim, one of our early volunteers who helped develop the program. And she's all ready to go with her doula uniform and a bag full of essential oils, socks, hair ties, lip balm, you name it. There's a rebozo in there, all kinds of things that we might use at a birth. So the doulas come in, grab a bag, attend the birth, and then put back the bag before they go home. We have another much smaller component of our program that we call client referral, and this is where a doula is matched up in advance with somebody with special circumstances, and it's often a request made by a provider, social workers, or nurses sometimes, or even self-identified. The women can call me and kind of give me this story and ask if there's somebody who can meet up with them prenatally and then remain in touch. So that's a bigger commitment, and the assigned doula is going to be on call for days or weeks for this one woman, and then she will come to the hospital when she's in labor or sometimes even for a scheduled cesarean. We don't offer this service to newer doulas. It's somebody we really know to be an experienced or seasoned doula because there might be a significant psychosocial issue, complications up to and including IUFDs. Okay, so how we maintain the program. This is why it's a full-time job for myself and one other person working half-time. And people always want to know right off the bat, but how do you pay for this? So the big question here is, what kind of program would you like to develop? If you're listening to this because you're considering it, I would like to really strongly say what I'm telling you about now is what we look like today, and it's light years from where we started 17 years ago. I actually think it's probably easier to start small and introduce change kind of quietly in a big organization like a hospital setting. It's challenging enough anyway. We did go from very grassroots and self-funded for a couple of years before we got our first grant, which was a 12-month grant from the First Five Commission that did pay salary and helped us buy some big ticket computers, office furniture, and things like that. And then we got an even bigger 2-year grant from the California Endowment. And that one asked UCSD to kick in with some sustainability efforts. So at that point, they picked up salary for myself and my part-time assistant, and we've been here ever since after the grant was over. And I would especially like to say how proud I am and grateful that I work in an organization that committed to our program. So, and like I said, even building a new hospital with a doula office planned within it was something I don't think you see everywhere. So the bottom sets of points on the slide, I do also want to say that we're very active in coming up with funding of our own, other than the office space and equipment now and our paychecks. Everything else is paid for by the doula program itself from within. And that means that we charge a small amount for our 2-day training. We have the donations that I mentioned, and we also do fundraisers. And this is a picture of 3 of our volunteers and 1 maybe future volunteer. But we do a huge bake sale, and we also do $1 a minute chair massage. And we do this in the lobby of the hotel where a ton of people pass by. So it's not just for the fundraising, but also awareness. It's a great way to just let people know about our program. And a bake sale sounds pretty small and sweet, but I can tell you that we're pretty aggressive about letting people know about our program and making sure they walk away with a cupcake or 2. This year we raised well over $6,000. And with that money, by the way, we do things like buy peanut balls for the hospital labor and delivery. We put on other events for ourselves to celebrate and particularly acknowledge milestones for the doulas. They like to be acknowledged. It's their way of being thanked, essentially. So I also really need to emphasize that we never, ever would have gotten this program off the ground and continuing so strongly without the support and encouragement from the top. And since the beginning, we've had the blessing from the School of Medicine's Chair of Reproductive Medicine, the directors for nursing, volunteer services, midwifery, all on board. And they ensure that whenever new staff comes on board, that I am able to go and in-service that staff and let them know that we have that support as well. So we do need to be in constant communication both with the community. We want to let people know about our services if they're pregnant. We want to let our community connections, agencies that work with UCSD, we want to let them know about our program. And we also have to be in touch with the staff. We're a teaching hospital, and that does mean that there's every year new staff coming in. And so just letting people know updates about the program, specifics about some of our doulas to kind of make it real and personal. And that's time consuming. It's also fun. Day to day, this is what I do, and I've had quite a few nurses call me. They've been tasked with, or they're considering developing a doula program as part of their regular work. And all I can tell you is I have a very full-time job, and my assistant Heather works 20 hours a week as well. So the way our program is currently running is not something easy to sort of do on the side. Although, as I said, perhaps starting a small doula program and building up might be a better way to go anyway. But documentation and recruitment, volunteer intake is daily. Also daily is data entry for the birth logs. We're pretty meticulous about collecting data, and we have our own database. That database was paid for with our original grant. Excuse me. We also keep pretty good documentation of our conversations with our volunteers. We have about 50 volunteers on our roster at any one time, and it's hard to keep track of them all. So just simply keeping notes on who's got what going on, who's taking a break, whose mother is sick, that kind of thing, so that we can support them emotionally, but we can also track the calendar scheduling. That's a moving target because as volunteers, if they need to change their plans or their schedule, their doula shift is going to be the first thing to go. Also setting up that new doula 2-day training every other month takes a bit of work, and we try to come up with a really good in-service every month at our doula meetings. I also represent the program at weekly and monthly hospital staff meetings, as mentioned in the description at the beginning, and that's a way to keep the program visible too. And again, attention to the volunteers. There's the basic 3 R's of volunteerism, which is recruiting, retention, and recognition. I can't say enough about that. If you're going to be working with volunteers, they need your personalized attention, they need feedback, they need guidance, and they need to be celebrated. It's their paycheck, basically, the thank yous that they get. And so we do daily, monthly, any way we can find to thank our volunteers and to notice their efforts. Thank them for milestones such as X number of births or hours given. And we have an annual event, usually a big dinner party with some kind of extra event going on with that. And that is where we celebrate everybody, including our staff, and we name a Volunteer of the Year. And if you can take a look at the names on here on the upper left, Bobby Hawkins is one of those volunteers that has been here for years and years. There's an old saying, 20% of the people do 80% of the work, and she's definitely one of those people. So cultivating a volunteer who just feels like it's part of her life is something that is very worthwhile. We do also have doulas who come and go, much quicker than that. Maybe 6 months is as much of a commitment they can make. But in this photo, also on the upper left-hand side, if you can see the name Jane Williams, she started a couple years before she earned that Volunteer of the Year acknowledgement in 2004, and she only just hung up her doula shoes last December. So that's a pretty good run, more than 10 years as a volunteer here. So again, back to the question of how can you get people, would you be able to get people to volunteer for such long hours and grueling work? Yes, you can. So day-to-day focus again, we're trying to increase our utilization. I would say that is still our biggest challenge. So believe it or not, 17 years in, we have doulas on call who don't get used. There are pregnant families who still don't quite understand what a doula is or how to access our services. And so that's communication. And then data collection and reporting on both our stats and our volunteer info is something that we utilize our database for. And stewardship of our volunteers is really our #1 goal. Long term, I just want to dive into our scheduling just a little bit more. So the doulas are on call for AM or PM shift. There's not always a doula available. Might not be anybody on the shift, somebody called in sick, or there's a full moon and we need 2 or 3 doulas. So in that case, we send out a group text page to our whole doula group. It's pretty ineffective, to be honest. Sometimes people can drop what they're doing and come in, but certainly there's no guarantee. If there were doulas available, they probably would have signed on to that empty shift. But it is a way of letting people know that we will do anything we can to try our best to get a doula, and it lets the doulas know that the hospital's busy and there's a need, and perhaps they can consider, checking their availability in, a few hours. And sometimes they can't answer that text first of all, but they call back 4 or 5 or 6 later and say, hey, does that mama still need me? I could come in now. But overall, our schedule is underutilized still. Only about 60% of the time are the doulas called in. So that's where our work is, we believe. And I think it's always going to be not 100% utilization of the schedule just because of that Murphy's Law, where it's busy and there's no doula, or the doulas are available, not needed, and scheduling is just tricky that way. So we do the best we can. Sharing information, which is what I'm trying to do now, is to just let other people know that our outcomes are great. We have proven to be a patient satisfier, obviously, and our statistics on our birth outcomes, clinical outcomes, kind of speak for themselves. So we're happy to share our model or help other people who want to talk through their ideas for maybe a different kind of model of care, because this isn't the only way to have a doula program. But here's what we feel are our core beliefs of what we've learned over the years and why we think our program succeeds. So basic beliefs, there will always be people who could benefit from doula care, but they don't have access. They don't know about doulas. They couldn't afford a doula. They're not even sure what a doula is. There's still confusion about that. But there will always be women who want to be a doula just for the love of birth itself, money or not. Some of them are thinking about money down the line, becoming private doulas or becoming nurses or midwives or physicians. We have 3 of our midwives on board at UCSD, started way back when in our doula program, and 12 of our doulas have become MDs out there in the world, not working at UCSD, but we've had a lot of people go on to healthcare careers. But again, our main core doulas are just volunteer doulas. They don't work privately. They have no other aspiration except to feed their own soul with the work that they do, that they find a lot of pleasure in. And our healthcare staff, our team, really believe that working with in-house doulas is the way that they found their peace with what used to be, potentially an adversarial relationship. I've heard some stories from our doctors and nurses about doulas who they haven't enjoyed, but it's helped them to develop a greater understanding of private doulas and maybe not eye them with the same preconceived notions that they used to. So I think that cultures can be changed. I know that outcomes can be influenced. And what is next for our program in particular, we are going to continue to offer our birth assistance, providing care with accordance to each mother's needs and preferences during her birth. We want to continue to be a sustainable model, 17 years and counting. We're still going strong, so I think we're succeeding there. Our vision is for every woman delivering here to have a baby if she wants one. We still are going to work on that one. For me personally, I'm going to continue teaching and writing and talking to people who are interested in this topic as I am. I'm more than 20 years in and I'm not tired of it yet. So this is where our work is. And I am so happy that you tuned in. Again, I'm sorry for the AV situation here. It's something that maybe we'll sort out next time. But I think we do have time for some Q&A. And if not, you can also feel free to contact me separately. That is my personal office number on the screen and my email. So thank you so much for listening.
Thank you so much, Anne. That was a great presentation. I'd like to remind everybody that if you have questions for Anne, now is the time. We'll leave a couple of minutes if you want to type something into the chat box to ask a question. With the people that are on the line, it's not possible to unmute everyone due to background noise. So we'll give a minute for you to, if you have a question for Anne, and to remind you that this meeting has been recorded and it will be available on the CMQCC website under webinars later today or on Monday. And the slides will not be available as a separate download. We will be sending out a link to a short survey about this webinar so that we can continue to get feedback from you and provide you with information that would, and other webinars that will be really useful to you. So we have a couple of questions that came in, Anne.
Okay.
The first one is, do you require certification for your doula program?
No, we don't. And I can tell you that some of our doulas are certified, but if they're not, we don't require it. And I'm going to say something, I hope I don't offend anyone, but I believe that our doulas, by the time they are trained and vetted and mentored and work with some other doulas for a while, gain a lot more experience than doulas do who are certified. I'm a certified doula myself with several organizations, and I know what is required. And I do think it's a good idea for private doulas to get certified. But as volunteers, I think it would preclude a lot of people from volunteering.
So there was a clarification that you're training doulas from scratch when people, quote unquote, volunteer to receive the training?
Yes. Even if they are certified with another doula organization, we do require them to take our training as well. And that training is just the first step. And I can tell you that a lot of people tell me they've come out of doula trainings and even done their certification and still feel unprepared, inexperienced. And so I'm not going to require it. I think we provide it without the technical certification term.
Okay. And a couple other questions. So it pretty much is a train the trainer program, and is there a fee for the 2-day class, and do the volunteers pay for that training that you provide?
Yeah, so we charge $85 for 2 days, which is significantly cheaper. I feel like it's pretty well subsidized. Years ago, we used to offer it for free, and that was a you get what you pay for mentality. I think people wouldn't show up. They didn't think it was worth much. We put a dollar amount on it, and people took it more seriously, and they didn't cancel or just no-show for the training. And they're getting 2 days of very good training, and we provide a breakfast and lunch too, so it's definitely a good deal, that fee.
So someone says they are working on starting a volunteer doula program and they're getting pushback on malpractice coverage for these volunteers. Is there anything you can say to help us convince those that we're talking to them that this isn't necessary?
Well, we haven't, maybe knock on wood, but we've not found any difficulties there. Our volunteers are under the auspices and umbrella of volunteer services. For the UCSD medical system. They're covered for workers' comp and probably any kind of malpractice that way. I do feel when a doula stays within her scope of practice, that should be the least likely person to step into any kind of trouble that way.
Okay. And
I don't know if that answers your question.
Who teaches a doula 2-day program?
I teach it.
Okay. And do you have other folks that help you with that, or?
My sister Heather sits in, and she's taken over portions of it. It's sitting in and listening to one person for 2 days is not ideal. So I do try to change it up and have Heather teach some of it. We also invite whoever is around, a midwife, a nurse, a physician, to step in and chat too. But they don't formally teach any of the curriculum.
Okay. And this is a question that I have. Is it, do you think this kind of program works better because you're at a teaching hospital? Do you think it could work at a non-teaching hospital or a non-academic hospital?
I definitely think it could work somewhere else. I think that in the early days, perhaps they were more open to it because there were lots of medical learners around. But our new doulas are mentored by another doula at first, so you could say that they're used to having more than one healthcare provider in the room and potentially more than one doula in the room. But other than that, I don't see. I mean, I don't know that for sure. This is where I work, but I could see other hospitals utilizing doulas and welcoming them anyway. I hope so, anyway.
Okay. And what resources did you utilize to guide you in this process?
I'm not sure I understand that question. Process, which part of the process?
Let me see if I can unmute Jessica so I can find her. Okay, Jessica, I unmuted your line if you'd like to give a little bit more of what you're looking for in terms of resources for your question.
Okay, can you hear me?
Yes, we can.
Okay, great. I guess my question is, were there books, were there organizations, were there online educations that you used to help guide you through the process of starting this program?
Oh, for starting it. Okay. No, we kind of winged it, and that's why I'm happy to share lessons learned, what we've done along the way. But we did work with the guidance, or at least the blessing of the top tier of the hospital. Like I said, the chairman of reproductive medicine, who's an obstetrician, very well revered in his field. The midwifery director, instrumental in this program. So we kind of chatted things through, but in the early days, we kind of just showed up and did it in a very small way. There were just a couple of us, and as we grew, I think we became more professionalized and worked with everybody, the staff, volunteer services on steps that we did take, but there was no how-to manual, put it that way.
One of the other questions is, have you compared the C-section rates at your facility between those that had a volunteer doula from your program versus all other deliveries?
Let me think if I understand that question. Total
So
deliveries.
I think what she's asking is, for those deliveries who did not have a doula, what was the C-section rate for those deliveries versus the deliveries that had doulas? How many of those were C-section? What was the rate for those that had doulas?
That's something I'm actually working with a statistician now to learn how to pull our data a little more specifically. So I don't have that answer for you. Bottom line is I don't know. Our hospital rate itself is a little bit hard to pull apart because we have midwives in the mix who deliver about a third of all the vaginal births here. And so they bring the total hospital rate down. And so we would probably want to pull out, midwife births, which are just statistically going to be lower than physicians because they have a normal low-risk population to begin with. We serve more midwife patients than physician patients, so we'd have to pull it out that way. And I know with CMQCC, we want to look at NTSV rates, and I have not been able to pull that out separately either. But I can tell you our hospital rate is nowhere near 12.3%, which is the doula attended rate. Is it a pure number? Probably not. But is it a good number? I believe very much so.
Okay, great. And another question, have you encountered circumstances where mothers do not want a doula volunteer? Did you try convincing them that they needed a volunteer?
Well, if they're really struggling, sure, we offer it. We don't push it on anybody. But sometimes the nurses really see a family struggling, and she might say, "Hey, we have this doula. Would you like her to come in and see if she can give you some support? And if you don't want her, she'll leave." So they could opt out even after the doula gets there, and that opting out has happened a couple of times over the years, but truly it's been a situation where the woman was kind of decompensating and wanted everybody out of the room. And the only one that she could actually ask to leave was the doula. And sometimes it's the opposite. People want a doula and they don't even know what the doula is going to do. They've just heard like, I should get a doula. So they ask for a doula and they're here not even in labor yet, for example. Maybe they're here for an induction. Contractions haven't even started and they ask for a doula. And in that case, we might gently say, sure, let's wait a couple hours until you're, a little bit in labor, and then we'll call that doula in.
Any funding resources for starting a volunteer program that you are aware of that you could share with others on the call?
Oh, I wish I had a wonderful answer for you on that one. Short answer is I don't know. Longer answer is if you're in California, check the California Endowment. I've been meaning to contact them again and see if they have any interest in supporting other programs. First Five Commission, perhaps March of Dimes, or I do know of some hospitals that have pieced together some funding. They've used the marketing department, a little money from volunteer services, maybe a donor, a private family in the community who might want to contribute. So in other words, just instead of getting money all from one place, maybe you could tap into several different pockets of funding. That is the tricky part, which I hope that we can all work to identify.
Is this program suitable for student nurses?
Yes and no. We have some, but I actually don't accept very many student nurses simply because of the time constraints. They are taking a pretty hefty course load. They have projects to do. They work, some 12-hour clinical rotations, and they simply don't have the time often. We've made a few exceptions, and they've been fantastic doulas, though. And I do know that there's other doula programs out there that primarily work with nursing students, so that can work. I believe they mostly work on shifts, a little bit different model than ours.
That is the end of our questions for today, and we're at the top of the hour. Anne, again, I want to thank you for joining us and sharing this great information about your volunteer doula program. Thank you to everyone who joined us and was on the call today and for providing your questions. And you will be hearing from us shortly with a short survey and more to come. Thank you so much, everyone. Take care. Bye-bye.
Thank you. Bye-bye.
Bye, Anne.
Bye, Valerie. Thank you so much.